Hello friends, welcome back to my channel with a new video, and this is the series which I have started last time on the ancillary therapy. And just to kind of uh, inform you and share with you that this was the talk which I prepared a long back when I was in my earlier hospital. So that was my earlier affiliation. So this is the continuation of the fast hugs bid, and we finished the sedation in the last video. So this is a short video focusing mainly on thromboprophylaxis, that is the FAST. So as the name goes, we kind of it's a very standard practice to give chemoprophylaxis in the form of either a low molecular weight heparin or a conventional unfractionated heparin to all patients who are ventilated, and as we know, because they are on at a high risk. And predominantly it would be a chemoprophylaxis. As I said, if there is no contraindication for heparin, then used unfractionated heparin or LMWH. And if there is any contraindication for heparin, of course use the pneumatic compression devices or graded stockings or the sequential compression devices, and we'll come to that soon. As far as the drugs for DVT prophylaxis is concerned, heparin, which is an indirect thrombin inhibitor that complexes with antithrombin, and a very standard dose of heparin is 5000 units subcutaneous every 8 to 12 hours. And we need to, of course, be very cautious about the bleeding, the heparin induced thrombocytopenias, and the osteoporosis. They have a relative low side effect profile, relatively inexpensive and easily administered. So the unfractionated heparin would be probably a natural choice in a patient who is admitted to ICU and the cost is a concern. But by and large, at this point in time, I think low molecular weight heparin is a definitely preferred agent over UFH. So, talking about the UFH, the platelet count, which should be monitored regularly, and of course, with LMWH, as we see, these are the agents in the form of enoxaparin, dalteparin, sodium, and of course, the synthetic heparins like fondaparinux. And we also talk about the newer oral anticoagulation or NOACs or DOACs, that is famously termed as. Now, as far as mechanical prophylaxis is concerned, this is the device that increases the blood flow velocity in the leg veins, reducing the venous stasis. And it includes GCS or graduated compression stockings, which provides the compression in graduated fashion, which is firmest at the ankle and used mainly for ambulant patients. There are anti-embolic stockings, which are standard compression throughout and used for bedbound or non-ambulant patients. There is intermittent pneumatic compression devices or IPCs, which has inflatable garment wrapped around the legs, which is inflated by the pneumatic pumps, which enhances the venous return. And finally, there is something called as FID or foot impulse device, which stimulates the leg veins to mimic walking and reduce stasis. And it is, of course, used in immobilized patients. So, if you talk about a mechanical prophylaxis, you need to remember these four devices, mainly the GCS, the anti-embolic stockings, the IPCs, and the FIDs. So this is the IPCD, where you could see that there's a foot impulse devices and the sequential compression devices, and the anti-embolic stockings look something like this. So which prophylaxis for which patient? So for a patient who is at a low risk of VTE, uh, so you have a hospitalized for acute illness, yes. Obvious risk factor for VTE is does not exist. There is no risk of bleeding And of course, the treatment of choice is early ambulation and mechanical thromboprophylaxis. For the patients with moderate risk of VT, hospitalized for the acute illness, and there is obvious risk factor at least one, but no risk of bleeding, of course, we can go ahead and do a pharmacological thromboprophylaxis. If the risk of VT is high and the patient's admitted for acute illness with a very high risk factor for VT and a low risk of bleeding, still I would go ahead and do a pharmacologic thromboprophylaxis. And for the patients having multiple risk factors, of course, intensive pharmacological thromboprophylaxis is what is required either in a BD or a TID dose as far as UFH is concerned, and OD dose as far as LMWH is concerned. There is always a confusion, and this particular clinical entity always gives us that kind of enigma as to which should be the proper preferred thromboprophylactic agent. And we are talking about a neurosurgical patient, which would actually a natural choice with a mechanical VT prophylaxis. But of course, pharmacological VT prophylaxis for patients who have a low risk of major bleeding. So here this category would have an intracranial hemorrhage which starts 72 hours after injury. A craniotomy where we start the prophylaxis after 72 hours after the procedure, and a significant spinal injury or a surgery where we start it after 24 hours after the surgery. So this is a timeline during which we need to take a call and start the chemical or pharmacological VT prophylaxis. So, what are the clinical practice guidelines for venous thromboembolism prophylaxis in medically ill patients? So, for all acutely ill patients who are hospitalized medical patient at increased risk of thrombosis, anticoagulant prophylaxis either with LMWH or with the synthetic penicillins or with low dose unfractionated heparin is recommended, and this is 1B. Patient at a low risk of thrombosis, the use of pharmacological prophylaxis or mechanical prophylaxis which is not advised, that is 1B. Patients experiencing bleeding or who are at the high risk of bleeding, anticoagulation thromboprophylaxis is not recommended, that is 1B. For patients experiencing bleeding or who are at high risk of bleeding, the optimal use of mechanical thromboprophylaxis with the graded compression stocking or intermittent pneumatic compression devices, as we discussed, is recommended, and the recommendation is 2C. When bleeding risk decreases and if the VT risk persists, pharmacological thromboprophylaxis is recommended, which is to be substituted for mechanical thromboprophylaxis, and this is 2B. And patients who receive an initial course of thromboprophylaxis, extending the duration of thromboprophylaxis beyond the period of patient immobilization or acute hospital stay is not recommended, and this is 2B. So, coming to the take home message as far as the thromboprophylaxis is concerned in the intensive care unit or a critical care unit, pharmacological prophylaxis prevents a DVT and PE. It is a strong evidence. Does it prevent ICU mortality? Well, the observational studies which will suggest it may decrease the ICU mortality. Which agent to use? Fairly strong evidence to suggest that LMWH may be more efficacious in preventing pulmonary embolism as compared to UFH. Fondaparinux may be more efficacious in selected group of patients, especially the post-operative total knee replacement, total hip replacement surgeries, and mechanical devices may not be effective when used in isolation. So, I think these are the few of the pearls from this particular topic, and I think I'll stop here and will meet you in my next short video, which will be the continuation of the ancillary therapy in mechanical ventilated patients. That's all for now. Bye bye. Take care.